with Dr. Zlamoir Chisieki, please. Ideal yawl combined with vitrectomy surgery. Please, doctor.
Thank you very much, Professor Hussein, for inviting me here. And actually, yes, I'm going not to speak about the sclera-fixated IOLs, but something which I do for more than 8 years routinely in my vitreoretinal surgery. Actually, it's not the right presentation. The title should be Ideal IOL. It's not this is the second one presentation. So actually what we need from intraocular lens, we need a lens which provide good visualization during vitrectomy, also good visualization post-op. And we need a lens which provides the most stable diaphragm during indentation when we do vitreoretinal surgery. So, of course, nobody wants situation like the pictures like that, but in daily practice we face very frequently such situations. So silicone oil removal and anterior synechiae. The synechiae, they are always between posterior surface of the epithelium of the iris and the anterior capsule. And even when the retina looks good, we face very frequently anterior synechia. So how to avoid it? We can put a little bit triamcinolone in AC. Post-op, we can put also RTPA on. We can use hydrophobic lenses. And the idea behind the hydrophobic lenses is that maybe they are more adherent to the capsule, and therefore the cells are not exposed in the anterior chamber, and the irritation seems to be less. So we have lens in the capsule, but another idea is that we should have the capsule inside the lens. This is the idea from Professor Tassignon. The first patent was published in 20, so it's actually more than 20 years ago. The first one, the idea was introduced by Klaus Eckert. And how it works, we usually do anterior rhexis, 5 or 4 millimeter. We do also posterior rhexis. We should expose Berger space. After that, we do posterior rhexis according to anterior one to have quite exactly diameter of the rhexis. And after that, we inject the lens between both capsule. And this we can do it not only in pediatric cases, but in every vitreoretinal surgery. And I want to show you how the anterior segment looks like. This is the after the PVR retinal detachment due to ROP complications. This is left and right eye of this boy. This is 3 years old child, 3 months after the cataract removal. This is 20 years old after very advanced diabetic tractional detachment, 40 years old. Please note how it looks the pupil side, right and the left eye with the hydrophobic lens, and the right eye with the Tassignon lens after tractional retinal detachment. And this is how the pupil size with silicone oil filled eye after PVR retinal detachment. Even if you have very advanced pediatric cases like this 11 years old child, which where the hemangioma has to be removed. This is how it looks after the operation and how the anterior segment looks like. It's in my opinion, after so aggressive surgery, it's not possible to have that kind of situation with the normal back in the with normal lens in the back. So right and left side Tassignon lens and hydrophobic lens. So just to avoid the situation like this, so very small pupil, probably the posterior synechiae are behind the lens. This is the reason why the pupil is so construct. We can have that situation with the back in the lens, Tassignon lens. Thank you very much. It's also, this kind of lenses provides very stable diaphragm during indentation. If we implant this lens between two capsules, and when we do one capsule a little bit smaller than 5 millimeters, it's really very, very stable lens, whatever you do during the operation. It behaves like pseudophakic eye, where the lens was made, for example, 1 or 2 months before. So take home message: there is no synechiae, good visualization during operation and post-op, and very stable diaphragm. Thank you for your attention.
Thank you, doctor. Just one question.
Yes.
Posterior capsule opening, rhexis, can be done sometime, but in this case you need to do a big posterior capsule rhexis. Do you agree?
In which case? In the cases?
In the lens in the back, I mean, this kind of lens.
Yeah, if we make the posterior rhexis bigger, it's easier to implant the lens. That's right.
Yes, but my two idea are: is it convenient to open the posterior rhexis in such a way, first, and second, is so easy to implant the lens in this second rhexis that you don't drop the lens? I mean, I think technically it's more difficult. That's what your experience. I don't have experience. What do you think? That's it.
Yeah, yes, you are right. The biggest concern in this lens, it's not to make posterior rhexis, but to implant this lens. And you can do it in 2 ways. The first one, you can capture only the anterior rhexis, and after that you can capture the posterior one. That I'm usually doing if I'm not able to expose burger space. But if you are able to expose burger space, if you put visco agents behind the posterior capsule, you actually you put together 2 rhexis. So you can do it in one step to capture both capsules. But you are right, if we do posterior rhexis a little bit larger, it's easier to implant this lens, to fix this lens. I recommend that for the first cases, to make a posterior capsule larger. But actually you can, it's enough one capsule to fix this. So for example, I had for a couple of months live surgery in Poland with Professor Tassignon, and I've had posterior, and I have capture of the posterior, I have the brake captures, and I fix only with the anterior capsular rhexis. And it's also possible, if you have break in the anterior rhexis, to fix it only with the posterior one. So this is so.
Yes, but I mean,
yes.
Do you find that is technically difficult? Do you find that is technically difficult?
Just, everything at the beginning is difficult. Every technique, actually.
No, if you compare
your lens,
with
it's not easy.
No, if you compare with the standard way to implant the lens, I mean.
Yeah. It might be challenging. You're right. It's more difficult than putting in the back. You're right, but it's worth it. Once you see the post-op how it looks like. For example, in uveitic eyes, or in kids, in pediatric cases, you will never replace this lens. Really, when I saw it, I used to work in Germany in 2008. I saw, when I heard this idea, because Klaus Eckert started to do, I work in the same region, and he started I thought, what a crazy idea to risk something like this.
Yes, yes.
But after that, I saw the eyes, how they look like, and I never had the,
Definitive operation, I understand, I
yeah.
understand.
Uh, Thank you, Dr. Slamomir, for a very
Thank
nice
you.
presentation. Thank you so much.
Thank you.
Our next presenter is Dr. Wael Ahmed Awais, and Wael is going to present retropupillary iris class lens implantation in aphakic eyes, techniques and tips. Dr. Wael, please.
We usually have a problem in managing a case of aphakia in absence of capsular support. I prefer the retropupillary iris claw lens, and I will present you how I do it and my tips from a posterior segment perspective. The iris claw lens has a different haptic configuration. It is a biconvex lens, but the haptics are relatively straight and with a cleavage area, an area of cleavage in the middle of the haptic. The classic indication for me is a case of aphakia, regardless it is a dislocated IOL or aphakia on purpose in the absence of capsular support in the presence of intact iris diaphragm. This is the ideal indication for me for a retropupillary iris claw lens. The first point for me is that I manage this procedure as if it is a posterior segment surgery. I insert the trocars, the infusion line, even my chandelier, so that if I need anything in the posterior segment, I would go without hesitation. The second point, well, the incision. Clear corneal versus scleral tunnel, I prefer the clear corneal. It is easier especially in the implantation of the IOL, and I don't find a problem in the anterior chamber stability at all, because we can control and maintain the anterior chamber stability through controlling the infusion itself. This is a very critical point in the iris claw lens implantation, which is the IOL orientation, because we need to implant the retropupillary iris claw lens with the concave surface up, the convex surface down. Anterior concave, posterior convex. And so we have to check after we get off the lens from the pack which orientation it is. If I find that I have to make it the concave surface anteriorly, facing the cornea. And then we implant the lens. In implanting the lens, I insert, okay, and then, yes. We reduce the infusion power, the infusion height, a little bit, so that I wouldn't jeopardize the stability and the wound. I insert the lens. I go with my haptics underneath the iris, and I try to maintain the anterior chamber at this stage by injecting a viscoelastic material with the other hand through the corneal incision. Well, when I'm reducing the infusion height and in the same time injecting a viscoelastic material and maintaining the IOL with my dominant hand in the iris plane, there is no risk for the anterior chamber loss or iris prolapse or whatever in this situation. I do not use special instruments. I use the iris spatula, but a thin one, and I start by enclaving the distal haptic and then the proximal haptic that is close to the site of entry of my spatula. Once I have enclaved both haptics of the lens, I feel now I am done with the surgery. I place sutures, of course, because the first priority here is the IOL centration and the anterior chamber stability. I don't care if it is a sutureless surgery or not. But we do not perform a peripheral iridectomy, by the way, in this situation. This is a situation in which I had to perform, it is not an aphakia, but it will be an aphakia once I manage the situation. This is a dislocated, a subluxated IOL end bag. So I perform a proper zoniolysis with the probe and supporting with the iris spatula, and then after that I explant the IOL and the bag, the complex as it is. This will turn into the indication, the classic. It is an aphakia. It will be an aphakia. Now it is an aphakia. Intact iris, no capsule. So I would go on with the posterior, the iris, the retropupillary iris glow lens as demonstrated before. Is it the end of the history? No. We may think that once we implant a retropupillary iris glow, we have finished all our cards. Sometimes, but I don't do this now, by the way, there may be a condition in which there is an aphakia, and in the same time there is retinal detachment, aphakic retinal detachment. I used to do this, but I don't do this now, to do everything in one surgery. I implant the iris glow lens and I perform the vitrectomy for the retinal detachment and silicone oil injection and whatever. But now I would rather do it in two steps, two broad stages. The vitrectomy first and leave him aphakic or her aphakic, and then afterwards, after everything is stable, I would think about the retropupillary iris glow lens. But on the other hand, the presence of an iris glow lens would not hinder any further posterior segment surgery that may be needed later on in life, because the pupil can still be dilated without risking the disenclavation of the lens. And in itself, this makes you feel more secure with the presence of this lens. In addition, that it is easy to insert compared to the other extensive manipulations in other types of IOLs. That's it, and thank you.
To Dr. Abbas for nice presentation. Question to Dr. Abbas regarding this. You are using this artisan lens.
Yes, artisan.
Yes, this is artisan. Yes, Samir, please.
Professor Well, very nice presentation, very nice videos. Thank you very much for your insights in these videos. I would like to ask you why you don't do PI in retropupillary artisan.
The orientation of the lens, the structure of the lens, the optic is having a concave surface and a convex surface. If we place it, the diameter of the optic diameter is 5.5 millimeters. This is in addition to the concavity of the surface. There is no risk of pupillary block in this with this IOL. It is not a straight optic like the classical three-piece IOLs or the 6.5 millimeter PMMA lens like old times. And so there will always be a passage, a route for the fluids inside the eye, the aqueous, to find its way to the anterior chamber.
And you always put this IOL retropupillary, you don't put it over the iris before?
It is easy. It is easy to insert, so why would I put myself in the position where I am liable to the disadvantages of an anterior chamber IOL, like endothelial cell loss and glaucoma and whatever.
How many cases did you see dislodgement of the claw?
The iris claw.
Yes.
Well, I experienced this in 3 cases in my life, and but they were the classic setting was they were young aged, exposed to a severe trauma. A girl was jumping at the trampoline and
Yeah.
she fell on her eyes, and she had bilateral iris claw lens. One of the haptics disinclined.
And did you encounter? I encounter in most of my cases the iris atrophy at the sites of the claws. What's your opinion about that?
Well, actually, I didn't see iris atrophy in the eyes that I performed. Maybe I should wait longer and see them
Yeah.
after a long time. But I didn't experience this.
Thank you very much.
Thank you, Dr. Wael Ahmed Awais. And now I will invite our next presenter, Dr. Nicolas Labari from Georgia. Dr. Nicolas will going to present traumatic damage to iris lens diaphragm, a surgical management. Dr. Nicolas, please.
Well, thank you again. So this presentation is regarding with trauma of the iris lens diaphragm. So, and yeah. So mostly I have here the different series of different surgeries in different scenarios. So during the anterior segment trauma, we are having the damage of the iris. It can be the partial aniridia, total aniridia. It can be chorectopia, polychoria, or iris dialysis, in combination with the lens trauma, which is a luxation, subluxation, or in combination with secondary glaucoma or the retinal diseases. So this is a case with a dense vitreous hemorrhage. So in those cases, mostly it's not necessary to combine everything together. So this is a case when I divide the surgeries. The first surgery was just a dense vitreous hemorrhage. This patient lost the iris and the lens as well. So what I'm doing here is just a vitrectomy, and there's a second setting. Once everything heals down, I'm planning to do iris and lens implants. This is another case. It was a similar IOFB with a vitreous hemorrhage. The first, the hemorrhage was removed along with the IOFB. And after several months, I'm planning to implant the lens along with the iris prosthesis. So the one thing it is that I'm very much concerned with is incision size. If I'm using the incision which is more than 2.7, then I go back to use the sclerocorneal incisions because less than 2.7 is astigmatism free. That's why it's very important to me. I never combine the iris and lens, so never attach to one another because it requires a larger incision. First, I do the sclerofixation with the chariot technique. It's my preferred technique, mostly in more than 90% case I'm using. And then I suture the iris onto the remnants of the natural iris. So this is another scenario where I have near total aniridia, but the bag is intact. There is a small cataract. I do the cataract, anterior posterior rexis, puts a lens, and then another kind of the same company, but another kind of iris prosthesis without the meshwork, which is designed to be implanted into the capsular bag. It's very important to implant here the CTR before we implant the iris prosthesis, because sometimes the phimosis may push out the iris prosthesis and cause a lot of problems. So this is a regular iris dialysis, a mattress suture. I will skip this video, nothing very special here. So this is another type of iris prosthesis, which is an intrabag capsular ring along with the segmental cover. It's manufactured by Morker, probably familiar for everyone. So the same thing, the lens is implanted here, the first CTR, and then goes this type 96, which is by Morker. So this I'm doing in cases when there is not sufficient iris to reconstruct to prevent the diplopia. So then I'm rotating this blind side. It's a iris defect, and then I'm using the Sipser knot and suturing of the sphincter to reconstruct the inner part of the iris. So this is The cases when we have the combination with the iris trauma with the retinal issues, so there's a retinal detachment, and here I'm using the silicone because I'm planning to use the silicone oil. I will be using silicone retention sutures along with the lens fixation. So again, here is the Sharios technique, intrascleral fixation. I usually use the scleral tunnels, 25 gauge, along with the incisions, and mostly 3-piece IOLs with the PVDF or the PMMA haptics. The lens is fixed, and then I'm using here the 6-0 Prolin suture. However, 10-0 or 9-0 can be used as well. So 2 mattress sutures here before I go back to operate the retina. So once the anterior chamber is more or less reconstructed, then I do the vitrectomy, retinectomy, etc., etc. It's a standard procedure. And filling with silicone oil, I just would wish to have the mouse to forward this video. I just want to show how it looks at the end. It's quite long, I guess. Okay, so the next case, this again the silicone oil retraction retention sutures. The patient with a PKP, I have to skip this again. This is where I suture the lens. Actually, I fixate into the sclera along with the vitrectomy because it was a VMT and anterior chamber incarceration. So this is the last case. I skipped those because I will be running out of the time. So this is the patient with a luxated traumatic luxation of the lens crystalline as the cataract. This patient is having the secondary glaucoma as well. So I'll be combining the lensectomy, vitrectomy with the Burwell shunt. Once the vitrectomy is done, of course, I prefer to put the shunt into the pars plana region. So it's placed under the muscles. It's not shown here, it's sutured, and there is a partial thickness scleral flap, which I always raise to hide the tube. Here is the same technique. I'm using the chariot fixation of the 3-piece lens. After I'm done with the anterior chamber, so here is the anterior vitrectomy. Again, all the incisions are less than 2.7, 2.4 actually I'm using for these insertions. So externalize the haptics. So at the end there is no need for the suture, and it's a astigmatic-free incision. So mostly when we do such cases, we have to think about the refractive outcomes. That's why it's very important. So any kind of lens which requires more than 2.7 incision, so probably it's not the optimal. So then I'm doing the vitrectomy, and just for the demonstration, it's not necessary actually to stain the capsule, but I stain the capsule because you have to first eat up the lens capsule, because otherwise your phaco probe will not be efficient to destroy the nuclei. Then I do another 20 gauge incision to fit the phaco probe. It's a regular phaco probe, no necessary for the fragmatomy. I just remove the sleeve, the irrigation sleeve, close the irrigation line, and use a regular phaco probe. There is a PFCL to prevent the retina from falling to pieces. The suspicion areas are healed with laser, and there is the tube which is angulated. So inside I inserted the hook, PVDF hook, and covered by the same sclera, and this is a partial ear exchange, and this end of the surgery. So those were the series I wanted to show to you. Thank you so much for your attention.
Thank Nicholas, very encouraging and very nice presentation. Do we have any questions regarding this presentation from the hall audience? So yes, Slavomir, please.
Congratulations, very nice movies and great surgery. I had one question because I saw you put artificial iris in the cases when you had to put into the sulcus. I saw you try to preserve the remaining iris. There are some surgeons who cut it off completely just to avoid irrigation. I want to know your opinion in this topic. Which option is better?
Yeah, actually, that's very pity. I brought here only nice cases, and I didn't bring the complications related with the iris prosthesis, which is really horrible in case if we get prosthesis-related fibrosis and secondary glaucoma. So these patients mostly require multiple surgeries after that, and most of them are not doing well. So in regards of the sulcus placement, actually, based on my personal opinion, it's much better to fixate the lens if we don't have the capsular bag, fixate the prosthesis onto the iris remnants and not to suture it into the sulcus, because into the sulcus it's a more chance to get the iris related fibrosis and the secondary glaucoma. It's based on my personal observation about 10 to 12 patients. That's why I always try to keep whatever I have the remnants of the iris and the suture onto the iris.
I have one question, Nicholas. So I am more concerned when you have an iris prosthesis more than 180 degree. It's okay for small one quadrants, but when you have a 180 degree, how is the stability and later on the post-operative inflammation with this prosthesis? How it goes on?
Yes.
With the smaller piece as compared to the more than 180 degree.
Yeah, so if it is more than 180 degree or 80 degree, usually I use a little bit bigger iris prosthesis because you need the more support. I do everything to not to suture the iris prosthesis across the sulcus. Okay, whatever I have the remnant, usually I use this remnant. If it's not enough to keep the stable iris prosthesis, then I pass one fixation through the sulcus. But mostly I try to not to do that. Yeah. Okay, thank you.
Okay. Now, Professor Hussain Kagan will speak about removal and refixation of dropped IOL.
Thank you so much. Can I have my presentation, please? So I will show you different techniques, a little bit about how to manage the dropped IOLs. So this is my first case. You see, the patient eye is aphakic, but he has got significant sulcus shelf over there. This is old type of intraocular lens, 3-port, and it's lying over the macular area. So my plan is not to fix it, just remove it and then implant the other IOL. So as a routine, I do the vitrectomy and I get the PVD, and then I just get it with the end grasping forceps and to bring it into the anterior chamber. So it is wise to use the perfluorocarbon liquid, but with experience you can do it without the perfluorocarbon liquid. With the end grasping forceps, I am bringing into the anterior chamber. You can use the handshake technique also in this way. So I am with the dialing hook, I am bringing into the anterior chamber. It's a little bit difficult because these have 3 haptics, and 3 haptics are very difficult to engage from the iris. So I brought it in the anterior chamber with the end grasping I'm holding, and with the simple Vanna scissor I'm cutting the lens. It's okay to do with the scissor. I'm not cutting it all the way to the intraocular lens, because when you will cut all the way, the second piece may drop back. So I am making it as a half pie. So bringing it from the 2.75 in CN, and half piece will come, and then the half piece. All the 2 pieces here you can see are engaged with each other. So you will not lose the second one. Other, if you will cut completely, then you will lose. And then I am planting the foldable intraocular lens in this eye. This is 3-piece intraocular lens, and completing my vitrectomy and everything. I complete all the vitrectomies with the dropped IOL with the PVD, and doing the much enough vitrectomy in these cases. So this is at the end of the surgery, intraocular lens is center and placed. So this is one more patient with the aphakic eye, and you can see the posterior capsule is on the inferior half only. So in this case, I could implant the 3-piece intraocular lens, but I tried to put the rigid intraocular lens. So here, the lens is dancing over the macular area. So you can watch this. It's sometimes very interesting. So then you do the core vitrectomy and you detach the posterior highlight. And similar way, I usually pick it with the end grasping forceps. So here I am picking it over the disc with the end grasping forceps, and similar technique, I will bring it to the anterior chamber. But this time I am not going to implant the foldable IL because I have plan for the rigid, because I have a very minimum anterior capsular support. So here I will do a large incision, because my next approach is the 5.5 diameter rigid intraocular lens. So I have enlarged little bit of the incision and just removing it from the large incision rather than making it. So this is a 5.5 rigid PMMM lens that can be easily supported and placed if you have a minimum capsular support. So here I am implanting the rigid intraocular lens. So this is the second way. When you have a good enough shelf, after removing, you can place the foldable lens. When you don't have enough capsular support, you can do it with the rigid intraocular lens. So at the end of the surgery, here you can see the lens is centered with the one suture. I don't leave the wound open in these surgeries, because these are vitrectomatized eyes, and make sure that they don't get hypotenuse, because vitrectomatized eye, when it gets hypotenuse, it's very difficult to manage in next. So this is another case, very little sport, but you can see the capsule is present at 12 o'clock and 6 o'clock only. There is a rip over 9 and 3 o'clock. Here I am just showing you that if you have some issue that you cannot have the other lens, you can even replace the same lens, bring it into the anterior chamber and replace the same intraocular lens. In this case, I had the difficulty to manage this patient with the other intraocular lens. So my plan was just to do the core vitrectomy, bring the same foldable intraocular lens and place it into the sulcus. So here you will see the technique, how we do it, so get a better stability. So doing the core vitrectomy, same technique with the end grasping forceps, you go, and I don't know why they are always lying over the disc area after doing the PVD. So all of you they love the disc, so I don't know. So did the anterior capsule, I watched there is a little bit sport at the 6 o'clock and there is a little bit at the 3 o'clock. So I just get rid from the anterior vitreous in the anterior chamber, and then with the end grasping forceps, I just holding the one haptic, and then I will bring it into the anterior chamber. So here you see, so it's bit easy to bring it into the anterior chamber. Sometimes it gets difficult when you have a soft eye. So maintain the intraocular pressure very precisely, and wound should be precise. So here I'm just doing the handshake technique and bringing it. The only thing, it's not difficult to bring the IOL out of the eye. It's very simple job. But bringing the IOL out of the eye and preserving the sulcus or the capsule, that is always little bit there. But if you are bringing the IOL and rupturing the remaining capsule also, then you don't have any option to place it on the sulcus or in the bag. So I am replacing the same intraocular lens, but as I have got the little bit support at the 6 o'clock of the capsule and 12 o'clock, so even the foldable lens at the 6 o'clock, but keeping the haptic at 12 o'clock, it gets good centration, because patient have the posture of standing all the time and facing ahead, so it has a minimum decentration. So it is after the surgery, the lens is well centered and suture is placed. This is one of our techniques. So doing the scleral fixation. So the similar scenario, but the situation is different. So I don't have any capsular support, and this is a rigid PMMA lens that is lying over the macular area. So situation is whether I should remove it and then get another lens and do the Yamane technique, or what we should do. So I plan to refix it, the similar rigid lens, as a scleral fixation, and didn't remove it. So this is our technique, how we do it. So meanwhile, during the video, I will explain the step. So I've just got the lens and brought it into the anterior chamber. This is rigid PMMA lens. I'm using the handshake technique because I need this lens in front of the iris. And then I will do the 90 proline scleral fixation. Our technique is that we don't bring the IOL out of the anterior chamber, neither over the sclera. We just prolapse one haptic from the 2.75 millimeter wound and then get the proline from the 6 o'clock and suture the haptic with the proline and then dial it towards the 6 o'clock, and then we prolapse the other haptic from the same from the same wound. So in this way, you see, I don't need to bring the IOL out of the eye. So these are the few steps. The only thing is that in this technique, you don't need to bring out the IOL. So it is basic technique for the suture scleral fixation. So here I'm bringing the proline from 12 o'clock. And I will bring the one haptic that I am going to fix at the 6 o'clock. I am prolapsing it from the limbal wound, and here I will suture with the proline. So now I have sutured it, now I am rotating it towards the 6 o'clock. It's similar as you do, but in this technique we don't have a lens outside the eye. So keeping it inside and rotating just inside that. So here it goes at 6 o'clock. And now just prolapse the 12 o'clock haptic, and similar you will go with the 12 o'clock haptic, and you can fix it similar way. It's very easy to say that I do scleral fixation, but the technique that most of the anterior segment surgeons use, they are more interested about the fixation of the lens, but they don't bother the posterior segment. They don't bother the choroids, what is happening with the retina, what's the status of vitreous, how the vitreous will pull the retina and get a GRT or something like this. So this is easy to bring something out and do fix it. But follow-up is sometimes very difficult in these patients. They get very difficult complications like choroidal detachment, etc. So these are few cases. So this is very interesting case I got recently, and was referred to me some of my friends. So one eye had the 3 intraocular lens. So he may need more things to do. So I got this patient with the choroidal detachment, and I couldn't find even any view of the fundus. I just did the B scan and found that there is a dropped intraocular lens. My concern was about the choroidal detachment. It was almost 180 degrees. So I was not much concerned about the IOL. IOL is just peanut to bring it out and fix it. But I couldn't get the solid choroid. So I have to puncture at 2-3 places to get the choroid back. So choroid was almost 360-degree detached. So you see, as I get rid from the choroidal detachment, I started the vitrectomy. Now I was relieved, but my relievedness was for very few seconds. You know why? One IOL is on the sulcus, and the other is lying over the macular area. I put the PFCL because choroid was not good and choroidal detachment, so I put the PFCL in this case. When I grasped the second IOL that is lying over the macular area, I found it's not one. These are the sandwiched 2 IOLs. You see? So what to do now? My question is the audience. One IOL rigid is on the sulcus and 2 IOL are lying in the vitreous. What to do? Bring all 3 IOLs out? Or how to do it? How to bring through the rigid IOL all these 2 IOLs? So I slightly shifted the rigid IOL away at the 6 o'clock, brought out the first IOL and hold the second IOL with my second hand. I was on the anterior segment. So I was dealing 3 IOLs with my 2 hands at the same time. But I was a little bit successful and lucky enough. And the main concern was not the IOL, the bringing these IOL and getting this IOL. Choroid was my main concern. I was getting hypertonic and hypotonic same time. So I just got the one here. Here the wound was not issue. Iris was not the issue for me because this eye was behaving very badly with the choroid. And one IOL is out, rigid IOL is there, and now I am going to, this is one gift. I don't know why the anterior segment put the 3 IOL. He may have finished at the second, but he make my life little bit difficult. So here is the gift for you, the second one. And I was lucky that I could preserve the third one. I completed the vitrectomy. I settled the chloride. For me, the concern was mostly about the chloride. All other are petty things, so you can do it. Then PFCL was removed, and the rigid IOL center, I'll traumatize a little bit the iris, but at the end, I was happy that patient got the 612 vision, and it was the patient from my very dear fellow. So, so thank you so much for your kind attention, and have a nice day. If any questions, I am here. Yes, please, Nicholas. So don't ask me about the iris repair. Can you take the mic?
But in those cases when we need to, probably, just a comment, when we need to remove one or several IOLs out and exchange with a new IOL, or we have already good IOL in the sulcus, we need to keep the same IOL, but the two more IOLs are into the vitreous and we need to remove it out. Instead of using the large clear corneal incisions, probably the best option here is to use a sclerocorneal tunnel, which doesn't require 6 millimeters. Mostly is enough just for the optic part to fit out, and mostly these incisions are not inducing the astigmatisms, and they don't require the sutures. So mostly this is what I always use when, or the large foreign bodies. I'll have for another sessions of video, the large foreign bodies to deliver through the anterior chamber. Probably instead of doing a large clear cornea which needs suturing, we have to be concerned about this. So it's better to do the sclerocorneal.
I agree that I should have scleral tunnel, and it's wise to have scleral tunnel to avoid the astigmatism, all the corneal pathologies. I do prefer to, but the issue is with the when you are doing the vitrectomy with the limited sources and everything, is the hypotony is the main issue, and I don't want to have a hypotenuse side. There is a scleral tunnel. If you don't suture, if you get hypotenuse, it's a very bad thing. Second thing, the hyphema. I hate the hyphema next day. That is more prevalent with the scleral tunnel. With the corneal incision, you hardly get it. So these are two concerns when I have to balance whether go for scleral tunnel or whether for clear corneal incision. If I get the incision just 12 days ago or 5 days ago or 15 days ago, then I prefer to open the corneal incision because it's not healed, it is already there and astigmatism is there. I don't like to enlarge the incision unless I don't have option of any foldable lens or any other option techniques. Well taken. Thank you. Sure. Any other question, please? Yes, please. Yes. So my protocol is that first I do the core vitrectomy, get rid of the vitreous that is engaging the IOL. Then I remove the IOL. After that, 100% I do the PVD in all the cases. Vitreous-based shave I do because it's very easy. The eye is aphakic. You can indent whatever you do. It's very quick. It doesn't take time consuming. Most of the cases, those I know the myopics, and they have the already any pathology in other eye. I do the 360-degree encircling laser at the end, but I leave the eye at the BSS, no internal tamponade except the BSS. So inducing the PVD is must, base shave 85% or 90%, and encircling laser on the pathological eyes if I find any break or any pathology in other eye of whether they are myope. So these are my protocols I follow in every patient.
Good morning, everyone. I'm Zaid Madanat from Jordan. Let me first of all say it's such a pleasure being here in Lahore among friends, and a special thanks to Professor Hussain for his lovely hospitality. Now, to kick off, we've seen wonderful videos by colleagues about inserting lenses. My opinion, to be clear, I think you should all learn different techniques of implanting secondary lenses, but specifically following trauma cases, I believe this technique is or has significant advantages. Now, I'm going to show you a young lady who suffered a blunt trauma, ended up with an iris sphincter tear and a subluxed cataract. My plan here is to take out the cataract and implant a sclerofixated lens. I use Gore-Tex sutures and a 4-point fixation. So I do 2 peritomies. I'm marking the sclera. You can go between 2.5 and 3 millimeters back depending on your approach. I mark the sites with a pen, and I use 2 of those sites to insert the cannulae, and the 2 others I just create a small sclerostomy like that to pass the Gore-Tex suture through. And in this particular case, I decide to take out the lens from the back. It's a young patient, the lens is soft, so I just use the vitrectomy cutter and I take out the lens. And after taking out the lens, especially in these cases, I ensure a full, proper vitrectomy is done, including shaving the vitreous base under indentation if possible. I also use a triamcinolone stain to make sure the vitreous has been fully removed. And here comes the interesting part. So I use a lens, in this case it's the LuxGood lens, it has 4 haptics. I'm inserting the Gore-Tex suture, the CV8 Gore-Tex suture, through 2 of the haptics on one side, and I insert the other half through 2 of the haptics on the other side. And these lenses have a couple of advantages. One is you don't need a big corneal incision to insert the lens. You can actually fold the lens outside of the eye and insert it, and I will show you that shortly. So after the Gore-Tex sutures are put in the eye and pass through the sclerostomies, the lens is folded, in this case using a McPherson forceps. The lens is inserted into the eye, it unfolds, and then you can start threading out the Gore-Tex and pulling the lens into place. I then pull the 4th end of the Gore-Tex, so you can see the lens is in place roughly, and then I tie the Gore-Tex sutures on either side, and I bring it to the desired tension. This step at first can be quite tricky, so knowing how much to pull and how much to tighten your suture, but with experience you'll learn how to do it. As you can see, the lens is nicely in place. The sclerostomies are sutured with atovicryl because multiple holes in the eye after surgery can lead to hypotony. We don't want that, of course, so the sclerostomies are sutured, and that's the end of surgery. I'll show you another example. This is an example of a patient, unfortunately, that ended up with significant iris trauma after cataract surgery. So this patient was referred to us after cataract surgery. You notice there's a superior about 3 clock hours of iris dialysis. The iris itself is not very healthy. So we start here by removing the bag complex. I'll show you different steps in this surgery. So how to insert the IOL. I'll show you different steps in this one compared to the previous video. I decide to use the main corneal incision that was used before, rather than to make new openings in the eye. Now here is after passing the Gore-Tex sutures through the lens, you start inserting them into the eye one by one. The most important thing here is to make sure you have a good orientation of the lens and try and remember which end of Gore-Tex goes where. Superiotemporal, infratemporal, infranasal, supranasal. So the Gore-Tex sutures are inserted one by one. Here I'm just using 1 forceps. You can use 2 forceps and do a handshake technique. That's absolutely fine as well. In this case, I use a 25 gauge, but you can use 23 gauge as well. That's absolutely fine. So grabbing the Gore-Tex suture, pulling it out of the sclerostomy. And I do 3, and I then fold the lens. In this case, I'm using proper lens folders rather than the McPherson. In my experience, both of them work just absolutely fine. So the lens is folded. This is an unedited video, so you're seeing it in real time. I like to use a notched forceps sometimes to open the lip of the corneal wound, so you don't cause any corneal damage as you're inserting the lens. And you can see the lens goes in nice and smooth. I tend to pull some of the threads to avoid any entanglement at this step. And you just let go of the lens and it unfolds quite nicely. I tend to push it to sink it under the iris, and then I insert the last Gore-Tex thread into the eye, and I go through the last sclerostomy to grab it and pull it out. I usually tend to leave the supratemporal one last. I find that easiest. And then this is after tying the Gore-Tex sutures. I use a slip knot here, so a slip knot can be easier. And then I bury the knot on both sides. So either rather than using a 3-1-1, you can use a slip knot and you can control the centration even better. And then the conjunctiva is closed with atovicryl And you can see this is the final outcome. Now, I'm going to show you pictures because I thought I was going to be limited with time, but this is a patient that suffered a ruptured globe. This patient ended up having primary surgery to close the cornea, and he had an anterior lensectomy and vitrectomy. So this eye was quite unhappy. So this is the first step after creating the 2 peritomies on each side. This is after I inserted the lens and pulled the Gore-Tex sutures from the 4 sclerostomies, as you can see. This is after the Gore-Tex was tied and the knot was buried. And this is what the eye looked like at the end of surgery with the conjunctiva closed. And with that, I thank you all very much, and I'll take some questions. So with my experience, the longest follow-up I've seen after these cases was about 7 years. And up to 7 years, I've not seen any problems with that thread of Gore-Tex under the conj. Now, my tip, or what I've been taught, is when you're closing the conj over the Gore-Tex, if you can pull some tenons with it, it helps. But personally, I've not seen any problems with the Gore-Tex line of suture under the conjunctiva there.
Okay, okay. Thank you, doctor. Thank you, doctor. Thank you. All the best.
Our next presenter is Dr. Slavomir, and he is going to present persistent hypotony after retinal detachment. Dr. Slavomir, please.
Thank you very much. Once again, Professor Hussein, I think persistent hypotony after retinal detachment, it's our nightmare, and everyone everyone knows it's actually end of the game. But let's back to the basics. Actually, there are 3 reasons of hypotony. We have iridoxiliaris cleft. We can have hypotony after PVR retinal detachment, and we can also have hypotony due to cyclitic membrane in uveitis. With the cleft, to manage the cleft after trauma, it's quite easy. There are several techniques. We can suture it. In my hands, the most effective is to do cryo. We do cryo after under the visualization. We stop the cryo when we see when it goes just only in the pars plana, not to in ciliary processes, just to avoid the damage of ciliary of aqueous production. So how it looks like in the practice, this is a gentleman after trauma with completely 360 iridodialysis cleft, and during the surgery, cryo in the ILM peeling due to maculopathy in hypotony, and during the surgery cryo in all quadrants, and actually immediately after the surgery, 1 week, we can observe in the swept cells OCT completely redetachment of ciliar body. This is unfortunately not the case in PVR retinal detachment. This is completely different pathology, what we have to do next. So we sometimes were able to recognize that the ciliar body, whatever it's still attached or not during the surgery. This is a case where we clearly see that the ciliar body is attached. But this is the second case with choroidal, also with choroidal retinal detachment, that actually during the vitrectomy we are able to recognize also ciliar body detachment, and even we can drain the subretinal, the subchoroidal fluid through the sclerotomy. So in that cases, in that cases, we actually recommend the 360 buckle around the eye. Why is that? We do a study when we involve 6 eyes with hypotony after primary vitrectomy, after actually not primary vitrectomy, but after many vitrectomies due to PVR, and they all have some kind of cleft causing due to PVR membranes, and we've done in all that cases 360 buckle, and we evaluated it with swept source OCT, and frankly speaking changed nothing. So in all that cases the cleft in ciliary body detachment was the same. So actually this is normal because we placed the cerclage behind the muscle, and the ciliary body it's far more anteriorly. But what we observed that we could increase the intraocular pressure from 2 to 4 millimeter, which sometimes was enough. So the only explanation for that maybe when we construct the 360 buckle or 360 cerclage, we blocked the uveoscleral outflow, and this is the reason why we increase IOP. So actually, basically, we don't need cerclage to attach retina or ciliary body, but to increase IOP and to support, yes, to increase IOP. Thank you very much.
Thank you, Slavomir. Do we have any question regarding these hypotenuse choroidal detached eyes? Yes, Nicholas, please.
Thank you very much for the lovely talk. My question is quite quick. With the eyes that are hypotenuse, do you
Yes.
try any medical measurements or any procedures before you operate to increase the intraocular pressure? Because, as we all know, operating on eyes with very low pressure can be quite challenging.
Yes. Actually, we didn't try any measurements, but we always plan to place cerclage with the vitrectomy, because actually there are no other option post-op except the new one, this cross-linked silicone oil, which is not on the market. What we use also, we use this Chinese product, this foldable capsular vitreous bag, and it makes sense because we observe that we can observe some kind of increasing IOP after a couple of months. So probably when we decrease the space, so the problem with silicone oil is when the eye contracts in phthisis eye, it goes to the anterior chamber, and it is not the case when we have closed capsular bag inside the vitreous chamber. So maybe this will be, but we don't need any additional measurements. Yes, Nicholas.
Yeah, another quick question. So with regard of blunt trauma, which induces a ciliary body cleft, no retinal detachment, no surgery before,
Yes.
so just blunt trauma and ciliary cleft. So we know that after initial hypotony, it turns to the hypertony because it gives us anterior synechias. So how fast do you operate the ciliary body cleft after the trauma when you see this patient the first day, let's say?
Actually, we do all that cases swept source, anterior swept source OCT or UBM, and when it's a cleft, it depends how many quadrants. But actually, if it's a small one and the hypotony is over, so when we do not see any signs of hypotony, so maculopathy, whatever, we can observe it. When not, of course, we can start with suture of the ciliary body, but I have a couple of cases where I failed. So now I immediately go for the cryo. Yes.
Okay, thank you, Dr. Slavomir, for nice presentation. Our next speaker is Dr. Carlo Carlevale, and he is going to present Carlevale IOL complications and management. This is his own invented research IOL, so we will like to learn and try to implant it in future surgeries. Carlevale, please.
Thank you, Doctor, Professor. Yeah. Okay. Anyway, as every procedure, even the scleral fixation of this kind of lens has several complications. How we can tell? we can tell intraoperative complication and postoperative complication. Classical is the rupture is a big lens. So once you insert in the cartridge, if you don't have practice, you may damage some part of the lens. What to do? If you damage one of these 4 arms on each side, you can leave it because the lens will be steady anyway. If you snatch the plug, you have to stitch it with some Prolene, the plug, so you can manage anyway. If you have a straight forceps, microcoaxial forceps, it will be a problem, especially in the deep set eye. So remember always to use a curved microcoaxial forceps. Is a very standardized procedure. So if you will make a big hole in the sclera, you will have some problem. I will show you. If you have a small incision, during the externalization of the plug, you may damage the plug, so you can snatch the plug in the eye. The advantages of this lens that is very elastic. So this is just an incomplete insertion of the cartridge, and the lens is pulled and jumps up. With a 3-piece lens, this job would we would have removed the loop. In this case, the colleague is using a big incision, a big blade, and on the way back is still enlarging the wound. So what to do? In this case is easy, because you just need to, you may stitch the wound with some nylon or some Vicryl, so the plug will stay in his own position. During some manipulation, the assistant holds the plug. Anyway, this is the most common mistake for the beginner. Because of the fold of the cornea and of the bleeding, the surgeon engaged something which is not the plug. The plug works like an harpoon, so the plug is already open on the other side. So the surgeon is in prison, is in cage. What to do? 3 chances. Push back everything and try to identify the plug. But the lens, if the eye is fully vitrectomized, the lens can fall down, can be diggling in the vitreous cavity. If you don't feel confident, some surgeon does not feel confident, one of other idea is to stitch this part of the loop on the bottom of the scleral flap. The scar of the sclera will hold the lens in his position. It will be slightly decentered, but this lens is a 6.5, so even if it will be slightly decentered, there will be no problem. In the case of the Yamani, if you have a decentration, there will be problem. Or, like the colleague Stylianos Skandarakis, that is showing, he showed this video in the American Academy 5 years back. He has a big incision anyway, so it's relatively easier. He was pulling in one side or in the other side till the plug jumps, externalized on the surface, that's it, on the surface of the sclera. If you have a big hole, remember, just stitch it. If you have a small hole, if you use a 20, remember that the T-shaped plug is extremely fragile. So if you use, or if you squeeze it with your microcoaxial forceps, you can easily damage it. In this case, I have is a classical situation of luxation of complex bag IOL. In this case, the surgeon is using not properly checked the forceps. So what happened that the plug remained just on the back side of the iris root. What to do? The plug is there, is not there, is inside the eye. Has not been so. First thing is to externalize the plug of the trailing optic. So at least one of the lens is stabilized to the ciliary sulcus. Once you have stabilized the first loop, the plug of the first loop, temporarily the loop is on the surface of the sclera, so the lens cannot fall down in the vitreous. Removal of the complex Berg IOL, and then putting some mydriatic. We have to try to identify the plug of the leading optic. Now, identifying the plug of the leading optic, the forceps, the new forceps engaged it, and externalize the plug of the leading optic, and the procedure is practically finished. After that, we should remember to clean the vitreous on the vitreous base, otherwise we may have a risk of retinal detachment, late retinal detachment. How to say? To say that all scleral fixation should be divided in partially vitrectomized eye or fully vitrectomized eye. In the partially vitrectomized eye, you have much less risk to drop the lens down. I'm talking from the principle of the anterior segment surgeon. So even anterior segment surgeon expert can do it. If the eye is fully vitrectomized, there is much more risk to drop the lens down, but you can also put one stitch to the lens to avoid that the lens falls down. That's the complication, the lens falls down, or in this case is the diggling of the lens. In the fully vitrectomized eye, the lens is diggling, so you have to again engage it and pull it back, externalize it, and the procedure is basically finished. This is a case that I was referred to me. There were problems. I mean, I could not see the flap, the corneal, the scleral flap, and one of the plug was broken. What I did, I suture with a proline the head of the plug, this one, with the proline suture. And then I pushed back in the vitreous cavity the plug. But you see how powerful fistula you can create if you don't protect properly with the plug. You see, properly with the plug, with the plug with the sclera. So I started to stitch with the proline suture and leaving then long strand of proline suture to avoid late decubitation. One of the classical complications also is the late decubitation of the plaque. This is I was repairing. I'm using I took a piece of the sclera from this side of the patient, and I'm putting a patch of sclera. But there is a colleague in the Moorfield Eye Hospital, Mohammed El Alfi, which is using patch of a bovine pericardium. Now we will see how will be the result. Other late complication was for the old model of the Carlevale, which is fully hydrophilic. The new model is hybrid, hydrophobically coated, and was tested for 6 months. Silicone oil, lens implant, detachment, silicone oil removal, like that. Retinal detachment first, silicone oil removal, secondary IOL implant, small opacification. This is a nice video from Evangelos Manusakis from Greece that shows how an old hydrophilic lens can be easily removed with a strong microcoaxial forceps and pulling slowly pulling from pulling the loop. There is a moment that the plug is luxated without any damage of the lens. So because the acrylic material does not interfere like the Gore-Tex with the sclera, so can be easily removed. And this is another reason why we have to protect with the sclera our plug. Otherwise, there will be late complication. Thank you for your attention. Thank you to Professor Kagan for the invitation.
Thank you, Carlo. We learned a lot from it, and I think people all over the world will start using it more and more. And with the few complications you have mentioned, so every technique has the few complications.
No,
everything has
any complication there are. I mean, anyway, this lens, there are 25,000 implants all over the world of this lens.
So every technique has some learning curve. Every technique has some initial complications.
You
but
have
the
to I agree with you.
know the IOL is behaving
You
very
have
good.
to manipulate the sclera. That's the weak point. It's a bit longer procedure if you compare with the Yamani.
Yeah.
But the special design of the lens avoid decentration, avoid tilting, avoid iris chuffing. The special design of this lens.
We totally agree and appreciate your efforts. Do
Thank
we
you,
have
everybody.
any question to Carlo? I think we are
It's
speechless.
late, it's late,
Thank
it's
you
late,
so
it's
much, Carlo, for your night presentation. And I will request the speaker to join me on the stage for group photograph. At this way, and conclude our session. Thank you so much.